Welcome to the 63rd session of Majlis Khonji. Please allow me to introduce our guest for this session, Professor Abdallah Daar, who will talk about one of the most important subjects, the COVID-19 vaccines, highlighting the science, policies, and ethics. Professor Abdallah is an Emeritus Professor of Clinical Public Health, Global Health, and Surgery from the University of Toronto, Canada, and he is a Senior Scientist from the University of Health Network. Professor Daar's academic career has spanned biomedical sciences, organ transplantation, surgery, global health, and bioethics. He has worked in various advisory and consulting capacities with the UN, the World Health Organization, and UNESCO, and he is a co-founder of the Grand Challenges Canada. He was a member of the African Union High-Level Panel on Modern Biotechnology and currently serves on the AU High-Level Panel for Emerging Technologies. He's a recipient of the University Avicenna Prize for the Ethics of Science. Professor Daar was the founding executive chair of the Global Alliance for Chronic Diseases. In 2017, he was made an officer of the Order of Canada for his work in global health and in establishing Grand Challenges Canada. His 7th book, Garment of Destiny, was published in October 2018, and recently he and colleagues launched a new book on development origins of health and diseases. Welcome, Professor Daar, to Majlis Khonji, and I would like also to welcome our session moderator, Dr. Ruqayya Dhahiri, a doctor of medicine specialized in medical law and ethics. She worked for Corona Pandemic Health Data Management Operations Center in Muscat region, and she was the legal support for the pandemic. She is also an activist in human rights. Thank you very much.
That triggers an immune response in the body of the person given the vaccine. And as we all know by now, the most important subunit of the virus is these spikes on the outside that give it an appearance of a crown, and that's why it's called corona, because it looks like a crown, because of these bits that are sticking out that are called spike proteins. The third method, which has become well known recently, particularly with the new two of the leading vaccines, is just using the genetic material of the virus, none of the other things. And then the genetic material enters our body, it makes our cells produce those spikes on the surface of our cells, which are then recognized as the virus, and our body then triggers an immune response. Next. Next slide. So there are three methods of using the whole virus. You can have an inactivated virus, in other words, usually killed virus, and then because it won't harm you, it's put into the body, your body produces an immune response, and you become protected. The other method in the center is called the live attenuated vaccine method. And here, the virus is not killed, but it is made weak, either by chemicals or by using other methods to just weaken it. So it enters your body, it's alive, but it will not be able to harm you because it has been made very, very weak. The third, which is on your right, is to use the viral vector method. You use a virus, such a weak, cold virus of humans or of other species, and you use that virus to carry the genetic material you're interested in into the body. And we'll come to that in a minute. I will explain, hopefully, if I can remember them all, which ones are made in which way. Next, please. So let's start with the subunit approach. this uses only that part of the virus that the immune system needs to recognize. And here, as I said, you can use different methodologies to put those spikes into the body, and then the body will start to make antibodies and T cells. In other words, it gets recognized by the immune system, which produces an immune response, and subsequently you're protected. Not 100%, but as good as 95 with some of the vaccines. So in the past, subunit vaccines have been used, for example, to make hepatitis vaccines, which are very well known and are given to all children at the time of birth. So it's a pretty safe kind of way to make vaccines. Next, please. Now, the genetic approach is the one that has become famous recently. And what you do is you use the genetic material for the protein that you want to make. In other words, in this case, we want to make the spike protein. So we can either use DNA or RNA. The easier to do is, and the safer one, is to use RNA. So we use mRNA, which is put into a little fat bubble after it's made chemically. It's not made biologically, it's made chemically. It's put in a little fat globule. There is no specific adjuvant, a stimulating molecule that's added with it. And it's got some simple solutions of salt and sugar. So it's a pretty benign kind of vaccine. Easy to make, can be made overnight, very easily. And we will discuss this point later when we talk about the variants that are coming up and how we can cope with those variants very quickly if they become a problem and do not respond to vaccines. Next, please. So biologically, in the body, what normally happens is that our body, in the center of the cell, in the nucleus, you have DNA, which is the hereditary material that every cell, almost every cell in the body carries. And that, in order to function, is transcribed in a process called transcription to make messenger RNA. That's the M in RNA, is called messenger RNA. So the DNA makes the RNA into a messenger. The mRNA goes into the part of our cell, which is a factory for making proteins. And so that's where, in the case of the vaccine, your cells will be making the spike proteins. We can come back later and discuss this in detail if needed, but I didn't want to go into great detail at this point. So I'll leave it at this kind of level of detail, and we can come back later and discuss them. Next, please. Now, I've only got one slide of policies, but as I go through, you will see that companies have policies, governments have policies, regulatory agencies have policies, and so on. But some of the examples is that, for example, the United States decided it would put billions of dollars into this program called Warp Speed. And that way, it would encourage research into vaccines and produce them very rapidly. And indeed, it worked. Nobody really suspected that we would have vaccines by the end of 2020, and that they would be licensed and being rolled out by the beginning of 2021. But that's what happened. Now, every country has a regulatory authority that licenses drugs, vaccines, and in some cases even food. And so vaccines, like drugs, have to go through stages of clinical trials, and then the company that's making them submits all its data in a portfolio to the agency in the United States. That agency is FDA, the Food and Drug Administration. And after a week or two of studying the data with experts, they say, okay, you can go ahead. And in this case, almost all vaccines have been licensed under what is known as emergency use authorization. So
are they FDA approved?
Yes, for under emergency use administration authorization.
But FDA, Food Drug Association, are they approved?
Yes, they are, yes.
Okay.
Yes. If you go to their website, there's a lot of information about it. Okay. If they were not approved by FDA, they could not be used in American citizens. In the in Europe, there is an organization called EMA. They do the same. And then countries like Oman, they will say, we will use it provided FDA has agreed and is used in America. So that's how it works.
Okay.
Another kind of policy is that research laboratories like BioNTech, the Oxford University where the AstraZeneca vaccine was made, these are research labs that don't have the capacity to make billions of doses. So they work with companies like AstraZeneca, Pfizer, etc., to make these vaccines in very large quantities, and they're huge production facilities, and they negotiate with governments to sell it, and then they have the logistics to provide those vaccines to the countries where they have been sold. Another kind of policy is, for example, here in Oman, we have 30, 40,000 doses of vaccines. Who do we give them to first? And quite often it happens to be the elderly, people over 65, or people at the front line who are exposed to patients who have corona or who work in areas where they can be exposed to patients who are asymptomatic with corona. And so those are the kinds of policies that governments put in. It's up to the individual governments to decide how they're going to use the vaccines. So age, people who are vulnerable, people with kinds of chronic diseases like diabetes and so on.
Yes.
Those are the ones that are prioritized.
And it is for citizen and non-citizen as well.
Exactly. And
it has to be distributed.
Yes, and it's given for free of charge.
Yeah.
Most governments give free of charge.
Yeah.
And up to this point, the vaccines are so much in demand that they are sold usually to governments only. They are not available to purchase from, say, pharmacy. But that will come. Once they have sold all that governments want to buy, then it will go to pharmacies and you can go and purchase them. But at the moment, they are only available through government mechanisms and usually for free. One of the important things that we will probably come back to with regards to policies is to ensure that there is equity when you roll out the vaccines, that, for example, you don't segregate, you don't discriminate against people of color or people who are of a different, women, for example, who are often somehow left behind or not get as much as the men do. In the case of people of color in the United States, they live in very poor areas, they are poor, and sometimes the vaccine distributors don't go out to where these poor people are, and so they don't get vaccinated. So these are the kinds of things that, yeah, go ahead, Dr.
Okay, Prof, a distribution of vaccine also will not be discriminated through rich and poor countries?
Yes, I'll come back to that. That's a very important point. I'll come back to when I'm talking about ethics.
Okay.
Thank you, Dr. Rokaya. So next slide, please. So just a quick summary of the kinds of vaccines that we have become familiar with. So from Germany and USA, you have Pfizer, which is making and distributing and selling the vaccine made by a company that was started by those two Turkish couple in Germany. And that has become perhaps the most successful vaccine so far, with a efficacy rate of about 90–95%. Similar to that is Moderna, which is an American company, and they have worked with the researchers at the National Institutes of Health in the laboratories of Dr. Fauci, actually. And then Moderna, the company, which was started by a Lebanese guy, now produces in large quantities and distributes them and so on. Another company, USA and Belgium, is called Johnson & Johnson, and that is the only one so far that has one dose. All the others require 2 doses separated between 3 to 5 weeks, but the USA Johnson & Johnson one is only 1 dose, and that is extremely important in countries, particularly in poor countries that do not have good transportation, so people cannot go back and come back. They have poor record keeping and poor facilities for storage of the vaccines, poor refrigeration. So this one is going to be a very successful one, particularly in the developing world, and also because it is not that expensive compared to the others. Another USA company is called Novavax, which is just entering clinical use now. I believe it's just been licensed in the UK and probably in the US quite soon. It's an interesting kind of approach to making vaccines. It uses a different kind of virus called baculovirus, and it's injected into the cells of moths, interestingly, and then the cells of the moth produce it very effectively. Then in Russia, we have the Sputnik vaccine, which you have all heard of, and Russia is making others, as is India. India at present has licensed and is already distributing 2 vaccines, one called Covaxin and the other called Covishield. Covishield is the local Indian name for the Oxford AstraZeneca vaccine. And China has also already licensed and is distributing 2 vaccines from a company called Sinopharm and another company called Sinovac. And they're already working on others. I should also point out that there are, in fact, research labs throughout the world that are doing research, and there must be maybe 100 other vaccines that are nearing the end of the research and will go through clinical trials and will be sold in the near future. So don't think...
Prof,
yeah.
With the too many vaccines on the market, that won't make confusion for people to choose which one and the efficacy, and it will be more towards commercial instead of, because when we got polio, it was one polio vaccine or smallpox, but now we have so many companies. So that also will affect people's faith in vaccine.
Yeah, so our vaccines that we have now vary in effectiveness somewhere from 50 to 95%. We might need more vaccines in the future. There is also a lot of learning when the researchers do these kinds of research. There is also the fact that at present, these manufacturing facilities from that make these vaccines, they're incredibly expensive. The smallest one will probably cost $100 million to build. So people are also working on how to make small factories that then can be developed or sold to developing countries, say for $10 million, so that developing countries are no longer dependent on these huge factories and can make their own vaccines very cheaply, very easily in Brazil, in South Africa, in Egypt, etc. So there are a number of reasons why the research continues. And then remember that only 1 out of 5 vaccines that is ever made is successful in terms of going through clinical trials and getting licensed. Mm-hmm. So although, let's say there are 100, in the end, there will probably be only 15 that will be successful. So there are various reasons to continue doing the research. Next slide, please. So we have all heard a lot about the variants which arise in different parts of the world. They arise because there are mutations in the virus, the living viruses. The longer they are in the community and the longer that they are infecting people and staying in the bodies of people, they mutate. Their genetic code changes a little. And particularly that spike protein, it changes ever so slightly. And by changing, sometimes it makes no difference, but sometimes it makes the virus more efficient at infecting people. And in some cases, it makes it more lethal after it has gone to the bodies of other people. And these variants, no matter what we do, they will continue to be in the bodies of people, and they will continue to mutate. And so we need to be aware of what variants are coming up. And the only way to do that is to track these new variants using genomics. In other words, every day take positive nasal swabs from 100 people, let's say, who have COVID. You send it to the genetics lab, not for PCR. The genetics lab looks at the genomic makeup, the genetic makeup, and tells you, oh yes, now we've got a new one. And that is how they discovered the ones in the UK. The UK has the most amazing way and capacity to look at genetic variants at the Sanger laboratory in Cambridge University. So every day from various parts of the UK, at least 1,000 samples from various patients are sent to Cambridge, and by the end of the day, Cambridge will tell you, okay, now we have to worry. In Birmingham, there is a new variant that's coming up.
And do you think how long this will continue? That a new variant and then again a new variant?
I think always. There will always be new variants.
But does this happen to previous diseases like polio and smallpox?
Well, it happens with flu, right? The commonest one is flu. The flu virus has new variants and mutates every year. And that's why every year we have to make vaccines for flu that are different from last year.
Okay, does it go into more to higher strength, or we don't know?
At the moment, the ones that have happened have been the ones that have become more strong in terms of infecting more people.
And infective, but not aggressive and patient.
Some, like the South African one, I believe, has become more aggressive in killing people. So now what should we do? Because these variants will keep happening. We will all have been vaccinated. But if there are new ones that are not sensitive to the vaccines, then they will cause us to get corona, new types of corona. So we're not totally protected. As it is, even if you get a vaccine that's 80% effective, 20% of people or 20% of the population are still likely to get corona. So I would suggest that you continue with the same safety measures that we have been using, which is hand washing, wearing masks, and now people are saying wear double masks because that actually increases the protection for people around you up to 90%. So actually it is more effective than a vaccine, double masking. Keeping distances is also incredibly effective. And additionally, I would say that buy a digital thermometer and an oximeter and keep these at home. They're very cheap, 5 riyals or so. Keep them at home. And if you start getting headaches, fever, sore throat, coughing, breathlessness, use the digital thermometer to tell you if you have a fever, and then the oximeter will tell you if your blood oxygen is going down. And if it drops to a certain level, you should begin to worry and you should call your doctor or go to the emergency department. But first of all, call the hospital if you can. Okay, next slide. Now, we have all heard a lot about herd immunity. And here's just a brief summary of the essence of what herd immunity is. So you will hear about different figures, like when 60% of the population has been vaccinated, then we will have herd immunity. Others will say 70%. I think it's more likely between 70 and 80% when the population has been vaccinated or has recently had COVID. At that point, you will get herd immunity. And what this means is that there is no longer exponential growth of new cases. In other words, until that point, one person who is infected will infect 2 people, 2 people will infect 4 people, 4 people will infect 8 people. So there is an exponential growth, like compound interest for those working in banks. Compound interest makes you rich very quickly, but it also increases the number of infections. Another way of putting this is, some of you may have heard of this number R0, which is also known as reproduction number. When the reproduction number is less than 1, it means that one person will infect less than one person. Less than one person means very soon the number of infections will begin to decline, and eventually in that locality, it'll die out, or at least it will no longer be a clinical problem. A few people may still get it, but it's not throughout the world, remember, it's just in that locality. So let's go to the next slide. Now, some of the terminology. What is efficacy and what is effectiveness? So efficacy is actually what we hear about a lot. So when you do clinical trials, efficacy is the fraction of people who have taken part in that trial, who are volunteers, who do not get COVID after being vaccinated. So it will be, for example, you give the vaccine to 100 people. One person who has got the vaccine will get COVID. 99 will not. On the ones who have had the placebo, not the vaccine, 99 will get it, one person won't. So at that point, you can say it's 99% efficacy. There is 99% efficacy. It's different from effectiveness in how the vaccine actually works in the real world, because doing a trial is not the real world. A lot of conditions are very tightly controlled. The age of the people is tightly controlled. The exposures around them are tightly controlled, etc. Whereas in the real world, even though you give people the vaccine, a lot is uncontrolled. A lot of people will still be reckless. Others will wear masks. Others will be living in areas which are very crowded. Others will not. And so effectiveness is how the vaccine works in the real world. Luckily, it appears from the evidence we have very recently from several countries, United Kingdom, Israel, and a few others, it seems like the clinical trial results are reproduced in the real world. In other words, efficacy and effectiveness are about the same. That's very, very useful data to know. It gives you confidence about the vaccines. Next slide, please. So a lot of people are interested in the side effects of corona vaccines, and a lot of people are frightened, and a lot of people don't go to get vaccines. There is hesitancy to go to get vaccines. But we know that more than 100 million doses of vaccines have now gone into people's arms. And so far, there has been no serious side effect. Anaphylaxis, which is an extreme form of allergy, is extremely rare. But it's the reason that you get vaccines in clinics, because if it does happen, the nurses and doctors in the clinic know what to do. And it's also the reason they tell you in the clinic, after you've had your shot of vaccine, stay around for 10, 15 minutes before you go. Because in that time, if you have anaphylaxis, it will come up. But it's exceedingly rare, and it is very treatable. The more common symptoms are local pain and swelling, sometimes redness. You get flu-like symptoms, mild flu-like symptoms, your body aches, you get a mild fever, and so on. And it is recommended that it is better not to take analgesics immediately before or immediately after you've had your vaccine shot, because that will likely just reduce the effectiveness of your immune system to respond to the vaccine. Next, please. So I think people are more familiar by now with the vaccines and their names than they are with the medications that have been approved or are in the pipeline for the treatment of COVID vaccine. The very first one is called Methylprednisolone. It's a kind of steroid, long-acting, given in large doses. If that's not available, it's very cheap, but if it's not available, you can just use ordinary steroids. This is for people who have had serious COVID and are admitted to hospital. And what you want to avoid at this point is for them to deteriorate, to require oxygen, or to be put on a ventilator. And we know that by the time someone is put on a ventilator, that is the worst stage of the disease. And a lot, not a lot, but a big proportion of people, particularly who have coexisting conditions like heart disease, diabetes, or who are elderly, will die. And that's why every day in Oman, we get statistics about how many people have been admitted, how many have gone into ICU, how many put ventilators, and unfortunately, every day we have 1 or 2 or 3 people that have died. Another kinds of drugs are monoclonal antibodies, and I've given you here the technical names. You really don't need to know. But monoclonal antibodies antibodies that are artificially made, which go to neutralize the virus in your body if you have access to them. At the moment, not many people have access to antibodies, but it is similar, but much more effective than plasma, convalescent plasma. So if you have had COVID and you have recovered, then in your blood, there will be antibodies. Now, those can reduce the severity of coronavirus in another person, but not as effective as monoclonal antibodies. Anticoagulants, you won't hear them being mentioned much because they're kind of routine now. Anybody who's admitted to hospital, I suspect even here in Oman, will be given anticoagulants. Why? Because the coronavirus makes your body, the blood in your body to clot. And if it clots, it will give you a stroke, it can give you a heart attack, it can damage your kidneys, it can damage almost anything because blood goes everywhere. And so people nowadays are routinely given anti-clotting agents, otherwise known as anticoagulants. Now, one thing a lot of people have heard about is that vitamin D probably helps to prevent COVID. Now, there is not very strong evidence for this, but we know that vitamin D boosts the immune system. If you have vitamin D in your body, adequate levels, your immune system is stronger. So theoretically, people who have normal levels of vitamin D will actually be better protected than those who have very, very low levels of vitamin D. And we know, for example, that in Oman or our neighboring countries where women don't go out a lot to drive and so on, women don't get exposed to the sun. Even men actually don't get exposed much to the sun. And if you don't get exposed to the sun, you have low levels of vitamin D and you need to have supplements. So for example, I take 20,000 units per week of vitamin D. Some people take up to 50,000 units. It is recommended to have that as an adult. Okay, next slide. I think we're coming close to the end of my talk. Next slide, please. Now, this is another area which is not particularly understood or talked about, and even more importantly, coped with. So people who are in isolation or in lockdown or who have reduced ability to go out for whatever reasons, they are on a wheelchair, they can't go out because they're unwell that week. So they suffer, not all, but a lot, from depression, from feelings of suicide. And we know that the number of people that have committed suicide, even in younger people in their 20s and 30s, has increased quite dramatically in some countries since the pandemic started. Anxiety is another problem, mental health problem. Insomnia, inability to sleep well, anger, particularly from people who have lost their jobs, feeling stressed. Stress is a very common symptom, and when it goes a bit excessive, you can get post-traumatic syndrome, stress disorder, post-traumatic stress disorder, which can be horrible. The number of women and children who are being beaten up by their parents, particularly the male parent, has also shot up in many parts of the world. I've put loneliness and highlighted it in blue because a lot of people don't understand the bad effects of being alone. So loneliness in this case is being in isolation on your own. and that has a lot of bad effects. It's equivalent to being in prison in solitary confinement, which has been declared by human rights organizations to be an inhuman and against human rights to put people in prison in isolation. It's the same kind of syndrome. It has a lot of downstream effects. And actually, if you don't touch people every day, that is the worst thing that can happen to you and your health and your survival. And this is why whenever we meet people, the first thing we want to do is to hug them, because lack of ability to touch people is very bad for your health. And then there are things like grief when relatives have died, friends have died, and then this long COVID syndrome. People who have had COVID disease, unfortunately, quite a lot. In some studies, up to 30% of people who have had COVID will have persistent symptoms up to 9 months afterwards, which is the longest that it's been studied. It might go on beyond that. And it can be in terms of what's known as brain fog. You can't think clearly, continuing loss of smell, continuing loss of ability to taste. It can be continuing the same kinds of symptoms that you've had, lots and lots of symptoms that people have. And unfortunately, there is a children's version of long COVID syndrome in children, which is not that rare. More and more cases are being found, and it can be very debilitating. Next. So Dr. Ruqayya may want to help me with this at the end of my slide. But she mentioned inequity within countries. I mentioned the within countries, poor people don't get as good access, and between countries. So for example, only about 10 countries in the world have amassed almost all the vaccines that have been manufactured so far, all of them. And the rest of the world have either not got even one shot or have got 10,000, 3,000 joke amounts that are not worth even discussing. Now, there is another thing about ethics, and that because people feel for some reason that they are immune, like I'm young, I don't care, I won't die, or because of ideology, people who are anti-vaccine anyway, and these are not all uneducated people, some of them have got PhDs and university degrees, but they don't want their children to have vaccines, but they don't stop there. They go out and advocate and try to change legislation to make governments not give their children vaccines, and so on. But essentially what happens is that these people then don't adhere to the guidelines. They don't wear masks, they don't care about crowded places, they don't wash their hands. And so they're putting all of us at risk, not only their parents and their grandparents, in some cases killing their grandparents, but they don't seem to stop. They just go on. And unfortunately, in the previous US administration, this was kind of encouraged to be reckless and so on. Then there are ethical issues in the prioritization of vaccine rollout. So we have heard that the best policies have been around giving them to vulnerable people, elderly, and people exposed in the front lines and so on. But other people are saying that the best thing is just to give everybody one shot as quickly as possible, and not worry about age and so on. And people are studying whether this is the right way to do it. Then there is vaccine hesitancy. Due to misinformation and so on, you will often get on your Twitter or wherever you get your news, false news, fake news, saying, oh, somebody got a shot and he died. The actual fact is nobody ever has died from having a vaccine shot. But this is making people hesitant to go and get vaccines. And this is why in Oman, our Minister of Health was the first one, Dr. Ahmed, to be given a vaccine publicly so that he shows, I'm taking the shot and you should also do that. And many politicians have done this, presidents, prime ministers, and it's a good thing. So vaccine hesitancy is another ethical issue. Vaccine nationalism is when governments are hoarding vaccines 5, 6, 10 times the amount that they need. So for example, Canada is a country that I know well, has got, for every one of its citizens, they have bought and are stockpiling 5 times as many vaccines. And that's stopping others getting access. Britain also has done that, not to the same extent, but what it has done recently, it has said that very soon we will actually be donating our vaccines to people in poor countries, which is wonderful, beginning with Africa. Vaccine hunters are these people who use unethical means to either get to the front of the line and get the vaccines first, or who pay and corrupt people to be given vaccines in advance before others who deserve them. Other problems are misinformation and disinformation, which is terrible. It can kill people by misinforming them about vaccines and about corona. I'll stop here with the ethics and see if Dr. Ruqayya wants to add anything. Otherwise, we'll go to the next slide, which may well be my last slide. Dr. Ruqayya, do you want to add anything here? You need to unmute.
Thank you very much for highlighting issues related to the vaccine and quarantine. Actually, it wasn't just a normal isolation of a person in 2 weeks, because it's carried so many financial, emotional, and psychological and social consequences, even in Oman. So I think, do you think we need urgent universal regulation when they put people in quarantine regarding financial income, because that will affect income of whole family?
If they are put in quarantine after
yes,
returning?
Because if the person is not going to work, and then this will add his psychological matters, and then the family whole will be a burden, run out of income for 2 weeks.
Yeah, so luckily it's 1 week and then you do a test and then you can go out on the 8th day in Oman. But as of now, starting last Monday, people coming from abroad have to go in institutions. So they have to pay 22, 25
Yes,
riyals.
and that's another burden on them.
Yeah, yes, indeed. Yes, indeed. And here you hope that the government, which will be humane and help people. But you know, in the long run, it's not this which is causing financial and economic problems. It's the fact that coronavirus and the pandemic has badly affected the economies of countries like Oman through fear, through isolation, through lockdowns. And also it coincided with the fact that people don't travel, so they don't buy fuel, petrol, and so the price of petrol dramatically went down. So there were very many reasons for economic suffering In
And
almost
about
all countries of
expats,
the world.
sorry, the expats who are staying here with very low income,
Yeah,
quarantine them alone. Usually they live together, like 20 of them in one room. Then this
yeah,
isolation, and who will
yeah,
pay for them? Also, there's another burden of expats who are working in this country.
yeah. Luckily, the government of Oman is humane, and it has given them choices to go back to their countries without punishment. I don't know whether they get help with the travel, but when these kinds of issues are brought up, there are either people who volunteer to help them from the public who can afford, or the government will ease their burden from the regulatory perspective and so on.
It's usually the sponsor who supports their travel.
Yeah.
And may I add one thing, because the raised hand is not functional with me.
It'll come soon. Yeah. Thank you, Dina. Go ahead.
Okay, the one thing that I think it's very important also is in terms of ethics is the likelihood that people, the mortality rate went up, non-COVID mortality rate went up during the epidemic.
Yes.
As we know, and that is because people were denied going to the hospitals because the hospitals were preoccupied with COVID patients. So that, I know it's not specifically about the vaccine, but it's related to the COVID issue, and it is an ethical issue that has a huge impact on nations.
Yes, indeed, and a lot of people died from heart attack.
Minister, but we started telemedicine to provide health service to people at home and then call them if it's necessary.
Yeah, so people are trying to find ways around various problems, but what is interesting is that the number of people with flu, ordinary flu, has dramatically gone down, most likely because now people are wearing masks for that. So in cold countries in the north, Europe, North America, the number of people with vaccines has dropped dramatically. And the number of people with flu has dropped dramatically. And usually every year in the United States, 1 or 2 million people will die from flu. So the number of deaths has dropped. So there is a kind of balance that has taken place. Okay, let's go to the last one. I think my next slide is the last one. So now we have vaccines. We have talked about all these issues, some good, some bad, medications, lockdowns, masks. Is everything okay now? So when will we reach herd immunity? Well, in Oman, at the rate we're going now, I'm sure it will speed up rapidly soon with vaccinations. We will not reach herd immunity before the end of 2021. And that is in fact, the case in much of the world, and in the poor countries who will not get a lot of vaccines in 2021. Herd immunity may not be reached until 2022, 23, 24. So it is best to continue with the masking and double masking, and also to remember that people who have been vaccinated and those who were previously infected can still become reinfected with variants, and they can still infect others. So this good public behavior should continue. Please continue to wear masks. Please don't hug people. Please keep your distance. Please avoid meeting in closed rooms with a lot of people. Then remember that even with the vaccine, even if you have had the coronavirus, etc., for those who have had coronavirus, even if they're given a vaccine afterwards, it will not stop them getting this syndrome called long COVID. So their symptoms will continue, and it might continue for more than 1 year, maybe more than 1 year. And there is a lot of research to find ways of dealing with the long COVID symptoms. A lot of it is related to just symptomatic treatment. But a lot of research is going into that. And I mentioned earlier this children's syndrome. We should not just assume that small children will not get COVID. They can get COVID, they can die, and if they don't die, they can get this syndrome. Then there is the question, what about going back to school? Some countries are saying that so long as vaccinations are available for teachers, and you test children who go to school once or twice a week, and you monitor their temperature and so on, you can go back to school. Others are saying it's not yet time. We don't want to put our children at risk. We want to reduce the exposure. And so they're doing combined teaching at home through the computer, going to meet their classmates twice a week, because not meeting your classmates, for children not to have exposure to the company of their classmates, is also bad for them in their development, mental development and health. Now, this is important. It's very likely that COVID will become endemic. It will not disappear completely. There will always be pockets here and there and so on. And it's quite likely that new vaccines will be required every year in the same way that we require vaccines every year, because the flu vaccine mutates. The same thing is very likely to happen with the coronavirus. And this is yet another reason for companies to be making new vaccines, cheaper vaccines, with smaller factories and so on. And then another interesting thing is that over the past 1 week, there have been statistics that show that the number of new cases of corona are falling in most countries of the world, in India, in the United States, in Europe. And nobody really understands why this is happening, what does this mean, and what to do about it. So it is something of interest at this point, but it is something that we should continue to keep an eye on. So I think that's my last slide. We will now open the discussion to members of the audience here, and Ruqayya will moderate and
thank you
help
for
us.
the informative presentation, Prof. Daar.
Thank you.
So please, anyone would like to ask any question or any comments?
If you allow me,
yes,
can
please.
I ask the question? Yeah, okay. I'm Abdul Dr. Abdallah, great lecture, I would say.
Thank you.
Very informative. Appreciate it. Just one quick question. Is there any correlation between hypochondriac or being waswasi, we call here waswas, and immunity? And if so, those who are hypochondriac are more likely to have a lesser immunity. Is that correct? Is there any correlation? That's my question. That's the first one. And then I'll follow it up with the measures that were taken in terms of how the media campaign that took place, whether it had affected people to be more susceptible, if you like. Thank you.
So the first question about waswas, which is an Arabic word, which is a little more than hypochondria. It borders on the idea of anxiety and stress. Now, anxiety and stress will affect your immune system by weakening it. And so I think that we should try to reduce anxiety and stress by calling our relatives, allowing people to go out for a walk, get some exercise. Exercise is good for you anyway, good for your immune system. So I would say that rather than labeling people muwaswasa, has waswas, better to try to deal with it creatively by helping them. I would not suggest necessarily taking anti-anxiety medications, because then those have side effects and so on. But no harm using telemedicine to talk to a psychologist or a psychiatrist about these issues, right? So that'll be my advice about waswas. Thank you.
Yeah, we
Can I
have
ask?
next question from His Excellency Khamis. Please go ahead.
Yes, can you hear me?
Yes.
Yes, go ahead.
Professor, really thank you. You save a lot of my time. I have been through all kind of reading material. This today you summarize everything. My question is in two parts. First of all, can we mix two kind of vaccine?
Okay.
The second question, why AstraZeneca is not active for the people above 65?
Okay. So the first question is, there are places which are actually doing trials of mixing vaccines. So have AstraZeneca and then have Pfizer. Or AstraZeneca and then have a third one, whatever is available. I have been an immunologist in my lifetime, and I can tell you that I personally, from what I know, there is no big harm. What you're doing is just like giving a booster to your immune system by mixing and matching. So if, for example, you have run out of your Pfizer, and now it's 3 months later, I would say if now there is only AstraZeneca, go ahead and have it. That would be my personal advice. But you would need to discuss it with your doctor if it actually happened in real time. But as I said, very soon we will actually have scientific evidence. There is a trial going on in the UK and other places to examine this very same question. Your second question was AstraZeneca and age. So this is a point that was raised in Europe, and it was based on the fact that AstraZeneca vaccine had not been tested in people above the age of 65. And so they said, well, we don't have evidence that it will work. They did not say that it will not work. And so it is still worth if you don't have anything else, take this AstraZeneca, even if you're 80 years old. It will still do some good for you. That would be my advice.
Any questions?
Yes, we have a couple of questions in the chat, and we have also Dr. Talal Al-Awlaqi raising his hand. Dr. Talal, please go ahead.
شكرا جزيلا ريهام. Thank you indeed, Professor Abdallah. Thank you to Dr. Ruqayya. My question is, Professor, when you mentioned about the genealogy lab and the importance of having frequent sampling from the ongoing COVID-19 cases to map any variant. As you know, Prof, there are lots of conflict zones around the world and some non-accessible countries where they lack such tools. Is there any way that we can come up with portable labs or something like that to address this grand challenge? Thank you very much.
Thank you for using the term grand challenge. But yes, there are actually portable machines that can do sequencing. They're not as good as the big machines in Cambridge University, but there are small machines. And if you are in fact focusing just on one part of the virus, which is in our case the spike, then it's even easier. The chemicals can be bought cheaply if it's just part of the genome that you're looking at. So the answer to your question is yes, it can be done. And this can be carried into the field, into refugee camps, developing countries, etc. Yeah.
Thank you, Dr. Talal. Thank you, Professor Daar. The next question is from Lamis. Lamis and Tariq. Lamis, would you like to ask your question, please?
The first one is, what's your view on the ethics of giving vaccines to vulnerable people when vulnerable is defined as, for example, going to work? Like in Indonesia, they're prioritizing people that are going to work and young people rather than old people, because older people are not necessarily going to work. And the second question I have is, what are your views on the ethics of the challenge trials that are now taking place in the UK, where they're giving the vaccines to people and then injecting them with the COVID vaccine?
How come we don't see you and Tariq, Lamis, Wenich?
Sorry?
We don't see you. Where are you?
هانش مش وانش هانش.
Okay, that was just a joke. So this Indonesian policy has been heavily.
We are not smart casuals, so we've decided to keep our.
Oh, okay. okay. So this Indonesian policy has been criticized a lot. And I really don't understand it yet, and I'm not sure that they're still continuing it. And it is counterintuitive to think that you can give healthy people who are going to work in ordinary jobs. If they're going to work in a hospital, it's a different question. Or even if they're working in a supermarket where they will come into contact with a lot of people, that's a different question. But if just all young people, while you are letting the elderly and the people with diabetes and so on die, that is terrible. I would say that would be considered to be unethical. The challenge one is very, very interesting. This is a subject that came up before the vaccines had been developed, and people were thinking, how can we develop vaccines very quickly? And they said one way would be, theoretically at that time, to get a few healthy people, actually infect them purposely with the coronavirus, and then test to see which vaccines will work and which medications will work and so on. But most people at that time, this was just a few months ago, said that it is totally unacceptable. It is not acceptable because we don't know the treatment of coronavirus. There have been challenge trials in the past. So for example, many of you will know that there are ways of infecting people with malaria by putting their arm into a box that has mosquitoes, which have malaria. And they would let them bite, and after a few days, they would start getting malaria. But then at that point, you know the treatment of malaria. So you would treat them and so on. But it had never been done with corona. Until last week, the United Kingdom said that they want to go ahead with doing challenge trials in about 100 people. They'll bring them into hospital, they'll be closely monitored, and they will be infected with the coronavirus to study the evolution of the disease, how much of the virus needs to be given, where does it go first, how quickly can you give medications to stop it, and so a lot of research questions. There's no doubt that there are big research questions, but it was thought unethical. But the British ethics system has given them limited license to do this for just 100 people to learn about it. And we're all watching very keenly to see what knowledge will come out of that. Thank you for asking that, Lamis.
Thank you very much. Next question, Sheikh Sam'an Karam, would you like to ask? You're raising your hand.
I'm finding a way to, can you hear me now?
Yes, we can hear you. Yes.
Oh, excellent, excellent. Thank you very much. Dr. Abdallah, thank you so much Every time you speak with us, you bring us knowledge and professionalism and science free of charge, as my friend, His Excellency Khamis said. We do little effort, but we learn so much from you. I owe you another thanks for mentioning a brotherly country, the Lebanon, you know, and their effort in this COVID thing.
Yeah.
That's good. Then you brought, before I ask three short questions, then you brought the idea or the fear of brain fog. Well, we have brain thick fog in many places, but we won't talk about this time. Now, I have three quick questions. The first one relates to responsibility. You see, who is responsible if anything happens? I know for sure that the companies have asked governments to take the responsibility for 2 years before they take their own responsibility. Is that correct as a statement? This happened in Lebanon. The parliament had to meet very quickly and approve a law that they will take the responsibility of the vaccine before the companies take that. Secondly, in terms of medication, many people say that Ivermectin can cure. We'd like to have your views on that if you've heard of Ivermectin. And lastly, maybe I suspect I know a little bit the answer because I'm an engineer. The immune build-up during the 21 days, does it go up linearly, or does it, I mean, how, by the 21 days, how much immune would we have improved? 80%, 70%? Thank you very much. Thank you.
Thank you. So 3 questions. The first one is about responsibility. So by that, I presume, correct me if that's not what you meant, responsibility if something happens to the patient, you mean, like insurance, medical
yes,
insurance?
Yes.
Okay. So this is one of the reasons that many companies don't like to develop vaccines, because of this issue. And as you say, quite often governments will take responsibility in case someone is harmed. Luckily, alhamdulillah, corona vaccine so far, no one has died to our knowledge. And there are a few cases where people after a month or so said, oh, my uncle died, must have been the vaccine. Well, we don't know. His uncle could have died from some other reason. He just had the vaccine. So essentially it is safe, and even the government that is providing the indemnity, it's called indemnity, do not have to worry about huge amounts that they will be liable for, from what we know. So that is the answer to your question number 1. Question number 2, ivermectin. Ivermectin is a very interesting medication. It is used in veterinary practice quite a lot. Why am I having an echo? I don't know why I'm getting an echo. I'll continue. It has also been used in humans for a condition called river blindness, which is common or was common in countries like Yemen and Sudan and so on, as a condition where there is a worm that enters the eye and it causes a huge amount of itching and people go blind in the end. So river blindness was treated by ivermectin. It is so cheap that the company that made it decided it wouldn't sell it anymore, just donate it to countries who have river blindness. Of course, farmers pay for it for their veterinary use. The third is that it is very cheap and has no side effects. Sorry, it has no very few side effects. So it was in the news about a month ago, but somehow it's fallen out of the news. Now, is it because it's not being tested, because companies will not make a profit because it is freely available, or it's effective but it is not as effective as other medications. The answer to that part of your question, I don't know. But it is worth keeping an eye on, because if it does work and it can be given prophylactically, in other words, before people get the illness, it will be very useful, because many of the medications are not prophylactic. You cannot give them in advance, like prednisolone and so on. So it's worth keeping an eye on, and maybe the Ministry of Health can look into this and give us some guidance through the app or in the media. Your third question is the rise of the immune response. So the immune response isn't just one thing. There is antibodies called IgM. There are antibodies called IgG. There are other kinds of antibodies. And then there are cells, T cells, that come in a complete immune response. And these increase at various levels. So I would say, in summary, the curve goes like this. In this kind of fashion. Yeah, I think that's yeah. But as I said, it varies on the molecule you're talking about and the cells, and then it will decay. It won't stay there forever. At the moment, the longest that we know that a coronavirus vaccine and antibodies last is about 9 months. So people who had corona disease 9 months ago are still protected, but we need to continue to monitor, because it might go down after that. Thank you.
So any more questions?
Mr. Simon, we commenting.
Can I go ahead with the question?
Yes, please do.
Yeah, hi. Thank you, Dr. Abdallah, for your informative and enlightening presentation. Dr. Abdallah, I have a question, very short one. Of course, subject to availability and managing the supply side of the production of the vaccines. And let's say within 1 year, do you think, or should it be mandatory to take vaccine to all the citizens, everybody? Is it something that is that you think is going to become a mandatory thing?
Well, at the moment, in no country is it mandatory. You can always say you don't want a vaccine for whatever reason. It's not something that health people would advise you to do, because you are slowing the rate at which you will reach the level of herd immunity. And so, in a way, it is antisocial not to have a vaccine. Will it ever be made mandatory? I think it depends very much on how this virus evolves. So if it evolves to the lethality, mortality rate, say, of Ebola, in other words, every person who gets it has a 60% chance of dying, and it is easily transmitted, gosh, I think that a lot of countries would make it mandatory. But I can't predict from now. And on the whole, vaccines are not mandatory in the sense that the law says so, but what the law can say is you can't go to school without having your whooping cough vaccine. So the schools won't admit you. So parents will automatically want a whooping cough vaccine. Or measles, which is the most infective organism in nature, most infective virus. So if you don't vaccinate your children, then we won't allow them into school. And you can see that there are also now people who say, no vaccine, no job. So you will not get a job, say, in a government office if you don't have a vaccine, and so on. So there are various ways of approaching this incentiveness. And these incentives will get more and more drastic and strong the more people die from the disease.
Thank you very much. Yeah, Dr. Dina Al-Asfour, you got some questions, please, if you may go ahead. You're muted, Dr. Dina. Just unmute yourself, please.
All right. Yeah, thank you very much. Thank you, Dr. Dar. I have one comment and a question. The comment is regards whether the vaccine will be mandatory. Well, according to the public health law, or it's due to come up sometime, is that if any person should comply with the government advice if it does have an impact on other people. That means, that was basically, and actually it was the infectious disease law, I believe, that if a child is, if a parent has to immunize their child because the child could infect other people if he gets infected. And should the vaccine prove effective for all kinds of COVID, I believe that would come up as part of the infectious disease law. It will come under the infectious disease law. That is in Oman. The question that I have is that what is happening in other parts of the world in terms of public education, because there is this dilemma of telling people everything when there are so many things that we do not know. As we know that every day there is something new coming up, and from following the World Health Organization conferences and weekly bulletins and all of these things, there's always something new, and even sometimes they are behind research. Like you find that research coming behind them, so coming ahead of them. So how do you think, in your views, that we should deal with this? First of all, a flood of misinformation that's coming from everywhere, and then the amount of information that should be given to the people in a way that they will comply with what you want as a public health professional.
Thank you. That's a really important question. So first of all, the public does need useful information given to them in a way they can understand, in the language that they can understand, and scientifically accurate. Now, this is not an easy thing to do. And the governments usually will take responsibility for this kind of activity, and the media, so newspapers. But where do they get their information, especially the newspapers? I think the best sources, call them reliable sources, are places like the World Health Organization. So the World Health Organization, has a very, very active website where you can go and look at the kinds of recommendations they are making, the kinds of research that's going, FAQs, frequently asked questions, and they have videos, 5-minute videos, which will explain an important point from a scientific perspective. Then they have a daily newsletter, World Health Organization. Subscribe to it. Just put your email, and every day you will get a newsletter from the World Health Organization, from CNN, from other sources of reliable information. And mostly this will not be information that's politically corrupted. So that's why I said reliable sources. In a country like Oman, the Ministry of Health has this Tarassud app, and it gives some information, but also there should be a way to ask questions from people like Dr. Ruqayya, the minister himself. These are people who are actually on some of the WhatsApp groups, but they can be reached easily through the Ministry of Health website. So it is good to be well informed, Don't take risks if you don't know the answer, but don't just keep quiet, find the answer. So that's what I would say about that. Unfortunately, there is a lot of misinformation out there, and it's as if there are people who enjoy misinforming other people and providing fake news and disinformation and all. This is a big, big international, global problem. And I still don't understand the psychology behind it. People either have an agenda or they just like to encourage mischief in the community. I don't know. There are now departments in universities that are doing research on misinformation and fake news and so on, to try to understand the logic and the psychology and the behavior behind it. So at present, unfortunately, just try to get your news from reliable sources, the ones that I have indicated. And if you see something that is looking a little odd, like it's probably not true, there is conspiracy theory, the first thing is don't share it. Spend a minute or two on Google to check if it's true or not. Go to fact-checking places like Snopes, and ask that question, and they will answer it, or it's already been asked by somebody else. But don't just automatically share things that don't look right, particularly on WhatsApp and other platforms, Facebook and so on. Don't do that. That just makes the situation worse. Thank you.
Well, thank you. My question was mostly about how to respond to people. Is actually how to reach people rather than how to get information. How to reach people.
So encourage them. You mean when they have done something bad, or just to encourage them to get?
The people who have misinformation, people who have questions, people who have, you know.
Right. Right. So from my recent experience, it is very difficult to change people's minds once they have got it in their head, particularly if there is a religious component to it. Mm-hmm. And they say, oh, my religion tells me I shouldn't have this. And it's often wrong. But once they have got it in their mind that have a vaccine is bad, it's very difficult to change their minds. But you can, again, tell them that this is what I know, and these are the sources. And if you want to be informed, for not only just for your sake, because you may be a mother who is now who are elderly person, but your children need useful information, encourage them to go to these reliable sources. Go to World Health Organization, go to websites that provide reliable information, and even send them to religious websites where they will get, usually, if there is, I don't know any mufti that will tell you don't get a vaccine, because vaccines were invented by Muslims 1,000 years ago. So you shouldn't be hesitating about that. And don't tell them off, because if you tell them off, they'll stop talking to you.
Yes. Yeah.
Okay.
Thank you.
Thank you, Dr. Dina. Professor Abdallah, if you may just take some questions from the chat. So there are some questions like how long the vaccine lifetime, and do we have to take them annually? And the second question is related to the same, is asking about if you recommend any vaccine among the others.
Okay, so the first one that I see that I haven't addressed is from 12:07 p.m. from the Lamis and Tariq to everyone. And some claim palsy is a possible side effect of the vaccine. Is this true? So yes and no. Palsy here, they refer to a thing called Bell's palsy, where the facial nerve is paralyzed for weeks to months. It makes your face look like this. It's not very serious. It doesn't cause much problems, and it is usually self-containing. It will go away. Now, during the clinical trials that were done, there were patients who developed Bell's palsy. It's called Bell's palsy. But when they compared them to the incidence of Bell's palsy in the general population, it's about the same. So very likely, the vaccines do not increase this side effects. They just reflect what would have happened anyway in the general population. So it is something like 10 people out of 100,000 or something like that will develop Bell's palsy anyway, and after a few weeks it will go away. So that's one. Then next question is, how long the vaccine time life? Do we have to take it annually? I think I've addressed this. So at present, it's recommended you have 2 doses, except for the Johnson & Johnson, which will be 1 dose. And then after that, nothing else. But because we're having all these variations, we might have to make booster doses. And those booster doses can be given after a few months. And if these variants become very common, then indeed we might have to have vaccines every year, just like we do for flu. I hope that by then every country will have factories to make them all over the world, and that it'll be cheap enough to be able to do that. Another question, we have heard that Cuba has developed very successful. How good is this information? The information is very true. Cuba certainly has developed a vaccine, and it is in, I think, phase 3 of a clinical trial. And Cuban vaccines, I would personally trust them, because I have visited Cuban biotech facilities several times as part of my work and as part of my research, and I know how good they are. They have often produced vaccines that other countries, including the United States, have not been able to make, and that they were buying from Cuba. So just because it's a communist country, or I think in a way it was a past communist country, it's medical products. It sells a lot of medications throughout Latin America particularly, and it sells a lot of vaccines throughout the world. So I would say don't worry. If it's from Cuba, so long as your country licenses it, go ahead. IT might be a risk-based judgment. Dina, can you please expand on that? I don't understand what.
No, I was just commenting on the Indonesia case. It might be that they had their decision was based on risk assessment of who might be more likely to infect themselves and other people.
Yeah. The next one, Dean, I think we discussed. You asked me about that. Then, how long the validity of the vaccine? I've just answered that. Where is the raise hand icon? Ask Nabil. It's there. I don't know where it is, but it's very easy once you.
Sorry, that's the question. It's not for you.
Excellent and very clear presentation, Abdallah. Well done. Thank you. Whoever says that to me, I can't recognize. They're called iPad. It may be my friends in South Africa. Oh, yes. Yes, it's Samira in South Africa. She's laughing. Next one is, Professor, do you recommend certain vaccine among those available in the market? So this is a question that comes up very often, and it's a very important question. So the first way to answer this is get any vaccine that you can lay your hands on. So if you have nothing but the AstraZeneca, please go ahead and have it. Don't wait for other vaccines, because it's much better to get 60% protection than no protection, and then get COVID. And COVID is a very serious disease. in many people. So I would say whatever the vaccine, get it. If you have a choice, of course, get the one that has a higher level of protection, Pfizer or the others. But if they're not available, don't wait. Don't wait. So that will be my advice. My friend Nick Patisone says, do we know why some people do not develop an immune response after being vaccinated? What is the difference in their body chemistry? So the kinds of people that do not get a good immune response, I think most people will get an immune response, but a good one is age, a common one. So people in their 80s, 90s will likely have a weakened immune response, and they might require 2-3 doses instead of 1 or 2 doses. Give them the third, give them the fourth, no harm. Others are people with cancer. They have a weakened immune response. Other are people with diseases that affect their immune system or that are taking medications that reduce their immune response. So for example, people with chronic rheumatoid arthritis who are taking immunosuppressive drugs, their immune system will be reduced. Another reason is people who have had kidney transplants or other organ transplants. They are given medication to reduce the immune system. And so they will not have a good response. And then you have to think about how to boost that immune response and so on. So those are the kinds of things, Nick. Next question at 12:42 from iPad 4, from my friend again in South Africa, I think. What do you think South Africa should do with the 1 million AstraZeneca vaccines it has purchased and does not want to use? Samira. So, my dear friend Samira, this has actually been decided by the South African government. They decided to give it back to AstraZeneca, get a refund and purchase another vaccine. And so I think they have already done that. Or I think they might have given some of it to the World Health Organization to send to other countries that don't yet have the South African variant. Because the AstraZeneca doesn't work that well for mild to moderate COVID. It does work for severe COVID though, funnily enough. Yeah, so it's a little of a mixed bag there. But I think South African government has decided that they would give it back and get a refund. Yeah, okay. Anybody else?
I think we have covered all the questions in the chat. And if we have, His Excellency Khamis, you have any question?
Please, Your Excellency Khamis.
Yeah, thank you. Professor, since you have mentioned about cancer.
Yes.
Do the people whom they have medication for cancer and they got their immune system down, do they advise to take the vaccine or not?
Yes, yes. The advice, and this also applies to women who are pregnant, but you'll have to check specifically with your own doctor. But even women who are pregnant, who have also a reduced immune response, are now being encouraged in many countries to get a vaccine.
Okay.
Because if they did get corona, it's a much more serious thing when you're pregnant. So it's better to get the vaccine. People with cancer who are taking medication that reduces the immune response, you have to take a vaccine that will not cause corona in the patient because of the reduced immune system. So some of the vaccines are called attenuated. Attenuated means they are weakened. But they are weakened in terms of someone with a normal immune system. For someone with a weak immune system, it could still give them the disease, serious or not serious. So look for a vaccine that is not attenuated. And luckily, the Pfizer one is not attenuated. The AstraZeneca is not attenuated. Look for a non-attenuated vaccine.
Thank you very much. Thank you.
Okay, there's another question came in the chat.
Okay.
I had the COVID-19 and I recovered. When it's recommended to take the vaccine?
Within 6 months. Within 6 months. The reason is you are protected for about 6 months. We know that from the data. So there is no need at a time when there is a great shortage of vaccines to go and get it. And also, you are assuming that you are in the category who are currently being given the vaccine. So if you're in your 20s or something, you don't work in a hospital, etc., you will still have to wait until your turn. But generally, the advice is wait for 6 months. Next one.
Yeah.
How has the current pandemic brought to light deep-rooted issues in public health infrastructure? Oh, beautiful question. And how can we learn from the current situation to improve our public health infrastructure? And this is from Mahir and Shaima. Okay, so it has revealed a lot of weaknesses in public health systems, which were already ravaged by poverty. A lot of very poor countries have very poor health systems, not all, but a lot of them. And a lot of these are in the poorest part of the world, in South Asia, in Africa, in some parts of Latin America. The rest of the world are lucky. Now you have Corona, which has not only caused the pandemic, but it has caused a lot of economic problems. But one of the worst of the problems it has brought about is malnutrition. Children are not getting enough food, and adults, but it affects a lot of children. And then their immune system is weakened further, and then they get other diseases, not just corona, other infectious diseases, malaria and so on, and they die. And so one of the things that the World Health Organization is recommending is to strengthen healthcare systems as we come out of the pandemic. On the other side of the pandemic, focus primarily on building your health systems. And one of the ways to do this, in addition to training doctors and nurses and building clinics and so on, is to provide universal health care, which is a complex subject. Some people have already adopted this, but universal health care is important to study. And actually governments know what is needed in order to strengthen healthcare systems. So that will be the short answer, Mahir and Shaima. Any more? There is one more.
Mr. Haji, do you have any question? Haji Adam?
Oh, Dina answered, improve primary health care. And she is absolutely right. That's the first place you want to improve, primary health care.
Yeah, thank you, Reham. Yes, I have a comment and a question. You kindly mentioned about, not to take information from WhatsApp. But in our...
No, I said don't disseminate things you see in WhatsApp before being sure that it is not conspiracy theory or misinformation.
Yes.
Yeah.
But in light of, in view of an absence of, official channels, here, especially here in Oman, we are, I think, kept sort of in a dark pitch. I mean, the officials come on TV once a week or twice a week, maybe twice a month, with a flock and a stick and warning with close downs and that kind of thing. We need, I think here, we need someone like you, I'm not saying exactly you, but maybe a similar channel
Yeah.
To come up once a month or once a fortnight, and educate us and tell us what's happening in the world. And if this happens, then will people stop listening, distributing, circulating fake information.
Absolutely.
But unfortunately, with us here in Oman, this is not happening, and we are only blamed, we are flogged, we are punished, and in return, nobody is taking the initiative to come up and educate the public. This is what I wanted to comment. The other question I have, maybe I sound a bit stupid, but does COVID and vaccine have different effect on different races like Africa and Asia? Because somewhere I read that the Africans were less vulnerable to COVID. And so in case of these vaccines, does it have different effect? Thank you.
Right. So Haji Adam, it's an honor to be talking to you and to answer your question. So your first question is really important. I can't do it, or at least alone. But there are these 5-minute videos, which I said that WHO produces, and I will look for some more, and these are totally reliable. What I will do is I will share them through Khalil on the transformation and others, and people, friends, and then they can share them with others, and then people will know how to get them. And if you look at one of these videos, say every 2 days, you will get the latest reliable information about various aspects of corona and of the vaccines. So that's my answer, and I promise I will do something about it. Secondly, your question about COVID vaccines, do they affect different races equally, and particularly Africans? So the answer is that is not true. The only reason that we have had African countries reporting very few cases is because nobody is testing. They don't have the capacity to test. In countries where there is a capacity to test, like South Africa, you see, look how big the burden in South Africa is. It's got more coronavirus cases than a lot of other countries per million population. And they are Africans, and they are Africans with different genetic backgrounds, because they are not all Africans of the same genetic background, and it is hitting them. Countries like Tanzania, for example, that have all the time said, oh, coronavirus, this is nonsense. There is no such thing. This President Magufuli. Then what happens is he tells people, if anybody reports coronavirus, they'll be put in prison. So people don't report. If anybody tests, you're not supposed to tell anybody the results. So what happened this week? One of his vice presidents died of corona in hospital. One of his senior ministers died of COVID this week, and several of his ministers are in hospital with COVID. So that answers your question, and also tells you that prayer alone doesn't work, because Magufuli says we are protected because we pray. Tanzanians, all you got to do is pray and you'll be okay. But we are taught, particularly in Islam, that that's not the way to protect yourself. You have to take steps to protect yourself. You can't just expose yourself to corona and then go and say, Ya Rabbi, sturna, Ya Rabbi, don't give me. God doesn't work like that.
Yeah,
so
thank you.
You have to take responsibility.
There is another thing also, actually I read about it in the Western media.
No.
Because Western world is extra clean and extra hygienic, and that's the reason their immune system is poor.
In Africa, you mean?
No, in Western world.
Oh, so the Western people have poor immune response.
Yeah, because they're extra clean, extra hygienic,
There is some truth to that, but it's not so much in terms of bad infections, but in terms of allergy. So children who do not get exposed to dirt, don't play with chickens, and don't play with animals, don't have pets and so on, they certainly get bad asthma. But if they play with pets and they play with chickens and outside and so on, they have less asthma. So there is some truth to that. But I've lived in Western countries, and I can tell you there are parts of Western countries that are dirtier than Africa. There are very poor people in these so-called wealthy countries. 30% of people in the US, for example, cannot afford food, and they go and get food from food banks through charity. So, you know, it's a mixed bag. You can't generalize, Haji Adam.
Thank you very much, Doctor.
Thank you very much. So we'll have the last question, then we will summarize with Dr. Ruqayya. The last question from Mr. Ali Dawood and Mr. Simon, if you have any final questions and comments.
Professor, three quick things. First, the team, we are here on the beach all listening to you. The first question is, when, in your opinion, Johnson & Johnson will be in the market? The second one, the Ivermectin is, how does it work biologically? And the third one, would you like to join us for lunch? We are all here in SIFA. Thank you very much.
Oh, Simon, you are always wise and entertaining. So Johnson & Johnson has already been licensed in the UK, as far as I know. And so it will be licensed in many countries very soon. It is a one-shot vaccine, and I believe that is about 80–90% effective. And so that is something to really look forward to. If I'm not mistaken and mixing it with somebody else, Johnson & Johnson has said that they will donate 1 billion doses for free to poor countries. So Allah yazidhum al-khair.
When? Do we know when? Maybe
Well,
roughly when?
Soon. They have contracts with the US government, and the US government has to be given them first because it has got this War Powers Act, and they cannot avoid that. They have to deliver. But once they have satisfied that and other contractual obligations, they will give it. Another good vaccine that's coming up is called Novavax. Keep an eye on that. That's not J&J, and it's 2 doses, but also will be rather cheap and very high level of protection, 90%. So, do I want to be on the beach? How long are you there for? But thank you. I can't make it today.
Until you come.
I won't be able to make it today. But thank you.
Yeah, please. And how does Ivermectin works biologically? Do we have an idea? Yeah.
Ya Allah. The short answer is I don't know in terms of the virus.
Good.
But it is it is an anti-parasite drug. So it works in the case of, you remember I told you these worms, loa they're called, which cause river blindness. It kills them dead. So it's an anti-parasite, just like anti-malarial drugs and so on. But how it would work in the virus, I don't know. I don't know. It'll interfere with some chemical pathway. That is my suspicion, some chemical pathway.
Thank you very much. Thank you, Professor Abdallah. I think we have covered all the questions, and we are also reached the time limit and exceeded as well. Dr. Ruqayya, if you would like to summarize, and then we close the session. Thank you very much.
Thank you, Raham.
You are muted, doctor. Yes.
Thank you very much, Prof. Daar, for the great presentation. And vaccination will always be a familiar, highly effective form of medicine and a tremor of public health, because vaccination is both an individual medical intervention and a central component of public health efforts. It raises a distinct set of legal and ethical issues from debate over the risks, benefits to the use of government vaccination requirements and make vaccine policy making uniquely challenging. Thank you very much.
Thank you. It's been my honor and my pleasure. And I will see you during other presentations in the future. And for friends who've come from far, like Hussein and Samira, where is Hussein, Samira? Ah, there he is. Who have come from far away, and those who also have come from far but have not shown themselves. Thank you very much for taking the time to join us. So goodbye and thank you very much.
Thank you, Professor Daar, for the comprehensive presentation and discussion. Thank you, Dr. Ruqayya, for moderating this session, and thank you, our guest, for your really active participation. جلسة الأسبوع القادم ستكون مع الفاضل هلال الشبلي، مدير عام مركز صناع عمان بمجمع الابتكار بمسقط، والذي سيطرح موضوع الابتكار ودوره في التوظيف الذاتي وريادة الأعمال. لأن نلتقيكم الأسبوع القادم. Thank you very much. شكرا جزيلا لكم. إلى اللقاء.
شكرا. مع السلامة.
مع السلامة. شكرا. مع السلامة جميعا واستمتعوا